Good morning, students. So today we'll be discussing about neurodegenerative disorder, which is Parkinson's disease, which is a type of senile dementia, which is a disease affecting elderly people. And as the average life expectancy goes on increasing, this disease is being increasingly prevalent in our society. So let's today try to understand what is this Parkinson's disease, what are its symptoms, signs, how do we perform its diagnosis, and what are the corrective measures we may take about this disease. Is it treatable or merely manageable? So we'll be focusing on all these points via my presentation. So I'll be sharing my screen now. Okay, so as we see here, Parkinson's is a chronic neurodegenerative disease. So neurons being one of the most important parts, which probably cannot be regenerated in our body using the existing technology, are one of the most complex parts of our nervous system, as we know. And Parkinson's is a chronic neurodegenerative disease. What are its cardinal features? Bradykinesia, muscular rigidity, resting tremors, impairment of postural balance leading to disturbances of gait and falling. So in a patient with Parkinson's, you will see these noticeable changes, that is decreased movement, rigidity, and resting tremors. Now resting tremors may be seen in certain other alcohol withdrawal type of conditions, but here it's pretty predominant. And the classic progression of the disease is what? That without treatment, Parkinson's disease progresses over 5 to 10 years to a rigid akinetic state in which patients are incapable of caring for themselves. So these symptoms, which earlier start as mild to moderate, go on progressively increasing in such a way that patient eventually becomes in a akinetic state. And death frequently occurs from complications of immobility, including aspiration pneumonia or pulmonary embolism. Obviously, when the patient stops moving around, all the circulatory collapse may occur, embolism may occur, and death usually occurs not because of Parkinson's disease, but because of the associated comorbidities. So let's have a look at pathophysiology of Parkinson's with help of this diagram. Okay, so what can we observe in this diagram? That there is a primary deficit in Parkinson's in form of a loss of neurons in the substantia nigra region in the midbrain, which provides dopaminergic innervation to the striatum. So basically what happens when these, for whichever reasons, now if the reasons we have seen are not clearly noticeable, but papers say that it's because of heredity or most of the causes are inherited or stress related. But actually, what happens, which has been observed after the post-mortem analysis of patients with Parkinson's, is that the substantia nigra region in the midbrain is damaged. Now, what happens because of this particular region is damaged? The dopamine synthesis is reduced. And then what happens? There is an imbalance between dopamine and acetylcholine in the brain stem, where the dopamine is less and eventually acetylcholine seems to be, or in form of action, appears to be more. If you closely look at this diagram, you will realize that there is dopamine, okay, which is getting metabolized by several enzymes. This is the normal system. Let's say which are these enzymes. Here you can see COMT, catechol O methyltransferase, or MAO, monoamine oxidase. These are the major enzyme systems. So in a normal functioning human brain, what happens is immediately as soon as dopamine's activity is over, it's taken back into its constituents back to the presynaptic level, and on demand it is released again. So but what happens because of the damage to the substantia nigra, the synthesis of dopamine itself is reduced, okay, leading to all the characteristic features of Parkinson's disease like bradykinesia, resting tremors, etc. Okay, so yeah, these are the pigmented areas of the midbrain, especially the substantia nigra. There is depigmentation and dopaminergic neuron loss. Free radical formation is thought to be one possible mechanism for these changes. Hereditary factors are another reasons. These cellular changes result in the loss of functional dopaminergic receptors, causing a decrease in overall level of striatal dopamine. What could be the possible treatment for this? If you look at the diagram, or commonly, if you apply some common sense, you will just come up with a simple answer that, sir, if dopamine is less, then why don't we clearly substitute it by dopamine? Well, substituting dopamine, it's a very labile agent. As soon as it's injected, it will be metabolized pretty strongly. And where it is required, in the brainstem. So crossing the blood-brain barrier will be another issue for actual intravenous dopamine, or even oral if administered. So that is not a feasible way. But we have certain similar mechanisms. For example, levodopa, the metabolic precursor of dopamine, is the single most effective agent in the treatment of Parkinson's disease, almost always administered with combination with a peripherally acting inhibitor of aromatic L-amino acid decarboxylase such as carbidopa or benzerazide. Now, what this says is levodopa, yes, which will eventually be broken down into dopamine, is utilized, but along with carbidopa, a preferential decarboxylase. Why is it so? There is a reason behind this. The reason is, if levodopa or dopamine is given single-handedly, what will happen is the drug will be largely decarboxylated by enzymes in the intestinal mucosa or other peripheral sites, leading to what the drug in form of dopamine will not be reaching the areas where actually the drug is supposed to reach and act. In addition, dopamine release into the circulation by peripheral conversion of levodopa produces undesirable effects. The effects are not desirable. Okay, it in fact worsens the cascade, because in the previous slide we saw that one of the reasons for Parkinson's, which is of course not proven but suspected, is free radical damage. Now, if free radical damage is there and levodopa is further going to worsen it by causing excessive free radicals, that will defeat the purpose of giving monotherapy with levodopa. So that is the reason why it is combined with carbidopa. This can be illustrated with the following diagram, where if you can note in the first diagram that levodopa alone, if given, out of the 100% dose which is given, only 1 to 3% of the dose reaches the brain, the actual area where the dose is required. Whereas if you give in combination with carbidopa, what happens is about 10% reaches. Well, 10% is still low as compared to the entire 100% dosage given. But if we actually see in percentage terms, the therapeutically effective dosage reaching this area of activity, that is the brain, is actually gone up tenfold, from 1 to 3% to around 10%. So this is the rationale for combination of levodopa with carbidopa. Which are any other significant factors we see with this levodopa use? It shows varying of effect on use. That is, initially the effects you get in the Parkinson's in the reversing the symptoms of Parkinson's disease like bradykinesia, kinesia, resting tremors, etc. is excellent. But on repeated use over the period of several months, it shows a varying of effect, or it goes on decreasing. How is this significant? It is significant because Parkinson's, being a chronic neurodegenerative disorder, it will be chronic, it will be lifelong, because the neurons are not regenerating back themselves. That is the reason. So we need some long-lasting treatment which doesn't wear off after effect. Production of free radicals as a result of dopamine metabolism contributes to a death of nigrostriatal neurons. Then the addition of levodopa actually might accelerate the process, the point which we discussed right now. The troubling adverse effect, which is again seen, is hallucinations and confusion. Second category of drug, which is dopamine receptor agonists. Now, enzymatic conversion of these drugs is not required for activity. They do not depend on functional capacity of nigrostriatal neurons. They have durations of action substantially longer than that of levodopa. For example, a drug of this category is bromocriptine. The duration of action of dopamine agonists, 8 to 24 hours, is often longer than that of levodopa, which is 6 to 8 hours. To minimize the adverse effects, the dose is built up slowly over 2 to 3 months from a starting level of 1.25 milligram twice daily after meals. The daily dose is increased by 2.5 milligrams every week depending on the response or the development of adverse effects. So basically in this disease, the dose has to be titrated properly based on the T-half, based on the fact that how the patient is reacting. The point to be noted here that patients are in this Parkinson's disease are usually from the elderly age group. They are having concomitant medications. They are having comorbid conditions. So before initiating therapy, there has to be a careful titration so that any other disorder cannot be induced or worsened. Okay. So dopamine receptor agonist can be in conjunction used with levodopa. Next category is catechol O methyl transferase. Now, if you remember the diagram from a few slides back, catechol O methyl transferase is a relatively recent developed class of drugs, but along with it, catechol O methyl transferase or COMT actually is the enzyme responsible for breaking down or cleavaging the dopamine after its activity. So, if we inhibit this by using COMT inhibitors, then the resultant action is going to be what? That COMT inhibitors will block this peripheral conversion of levodopa to 3-O-methyl-dopa, increasing both the plasma half-life of levodopa as well as fraction of each dose in reaching the central nervous system. So they will actually prevent or the levodopa which you have already administered or the remnants of dopamine which are being synthesized in that human body will be acting for a longer duration of time, thus relieving the symptoms. The drugs under this category are tolcapone and entacapone. They are useful in combination with levodopa as decarboxylase inhibitors. Control do not affect COMT metabolism. So that's an added advantage. Next category which we use is selective MAO-B inhibitors. Now MAO stands for monoamine oxidase B inhibitors. Obviously, when we say MAO-B inhibitors, question might be coming to your mind that, oh, there has to be a inhibitor or a non-specific inhibitor at least. So yeah, it is there. More discussion on that will be there on our lecture in the depression antidepressants, because it's a very useful over there. So MAO-B or monoamine oxidase B, as we are on the topic, I'll quickly touch upon what this MAO-B is so that you will understand better how it is useful or how MAO-B is useful in treatment of Parkinson's disease. So the biogenic amine theory says that whenever all the levels of biogenic amines in your brain system are high, the mood is elevated. And when they are low, for whatsoever reason, maybe pathological reason or maybe psychological reason, if they are low, the person goes into a major depressive disorder. So usually when you use monoamine oxidase inhibitor, first we will not discuss about A or B, just non-specific ones. What will be the resultant action of that? When MAO inhibitors are given, the MAO will be inhibited and the increased level of biogenic amines will be there into the system. Now, as soon as increased level of biogenic amines are there into the system, mood is going to get elevated. That is the reason why MAO inhibitors are used as superb or the one of the first ones antidepressant drugs. Okay, but here we do not want that. Why would we not want that? Because now along with such nice action, they also come with a side effect. Now what is the side effect? As you can see on this slide, somewhere we have mentioned about the tyramine reaction, also called as the cheese reaction. So what happens in this reaction? If a person consuming MAO inhibitors consumes diet rich with cheese, red meats, or even Coke for that matter, what will result is the amino acids, tyramine in these food stuffs is going to basically shoot up in the system, in the blood. In a normal human being, this can be metabolized by the existing MAO, but in the patients of Parkinson's, we have already given them MAO-B inhibitor, or let's say MAO inhibitors. What will happen? That the level of these amino acids won't be, or biogenic amines eventually, which they will get converted into, won't be controlled, and there will be a sharp shooting up into these levels, leading to what? A hypertensive crisis, maybe palpitations, and a patient is an existing heart patient. It may precipitate a cardiac arrest as well. That is the reason why we are not giving, and considering the fact that these people are already elderly, they may be hypertensive, we are not giving non-specific MAO inhibitors. Those are reserved for treatment of depression, which we will see in another topic. But we selectively give MAO-B inhibitors. Now, which is an example of that? Selegiline is a selective inhibitor of MAO-B, leading to irreversible inhibition of the enzyme. Selegiline also does not cause the lethal potentiation of catecholamine action observed with patient taking non-specific MAO inhibitors. Indirectly acting sympathomimetic amines such as tyramine found in certain cheeses and wine. So selegiline can postpone levodopa use. Now it is also postponing levodopa use because it is more effectively utilizing the existing dopamine which is there. This is the added feature because we are aware from our previous slides that as soon as levodopa use is started, it may lead to a wearing off effect and worsening of the free radical damage as well. Okay. Next category is muscarinic receptors antagonists. Now we have studied about these antagonists, and in our first part of the lecture, what was our presumption or the hypothesis that when dopamine level falls, acetylcholine level will appear to be increased, and this imbalance is actually the culprit for the bradykinesia and other outwardly symptoms of Parkinson's disease which we see. Now we are attempting, now till here we were actually playing with dopamine. We were trying to supplement its synthesis, or we were trying to inhibit its metabolism by MAO or COMT inhibitors. Now we are actually looking at muscarinic receptor antagonists. So for a change, we are now focusing on acetylcholine. So basically these are anticholinergic drugs in a way. So what are they going to do? They will act within the neostriatum through the receptors that normally mediate the response to intrinsic cholinergic innervation of the structure, which arises primarily from cholinergic striatal interneurons. Several drugs with anticholinergic properties are currently being used in this treatment. Now, what basically these drugs will do, they're being anticholinergic, they are going to reduce the action of the excessive acetylcholine and get dopamine and acetylcholine into balance, leading to the symptoms disappearing or reducing. Now, obviously, they are anticholinergic drugs and we are administering them. So they are going to have their own side effects. No drugs, no matter where you're using for Parkinson's, they are not going to leave their inherent properties. What we can do is we can select the drugs like benzotropine, which have lesser side effects as compared to other drugs on this category. But they are surely going to have anticholinergic effects like dry mouth or dry eyes for that matter, or blurring of vision, which is commonly caused because the lubrication of the eye reduces. Basically, all the anticholinergic drugs are going to dry up all the secretions in the body. Also, a more serious one is that they will be strictly contraindicated in patients with narrow angle glaucoma, because you know that anticholinergics will also cause mydriasis, leading to worsening of the intraocular pressure. And if the patient already has glaucoma, there may be damage to the optic nerve leading to permanent blindness. So this particular has to be taken care of. Okay. Now, other agents, that is amantadine. Now, these are not related to any category, but they are showing effects. Amantadine, we must have studied them in our antiviral chapters as well in the previous year. Appears to potentiate CNS dopaminergic responses. It releases dopamine from storage sites and inhibits the reuptake of dopamine and norepinephrine. Amantadine is clearly less effective than levodopa, but can offer additional benefits in patient experiences maximal or waning effects with levodopa, which we studied as wearing off effect. It may be useful in treating those effects. Now, some newer paradigms, newer perspectives, or what is the latest research telling us? Till here, we have seen that Parkinson's, no matter what, is not a treatable condition. It cannot be treated. Patients cannot be, implanted with any neurons. We do not have that technology currently, and patient cannot normalize back to a normal human life. But what we can do, if without intervention, the deterioration of the patient and eventually death may be occurring over 3 to 4 years, we may postpone it to even 5 to 10 years. That is what we have achieved with all this multiple therapy and utilizing combination therapy. Newer perspectives say that it would be desirable to identify a treatment that modifies progressive degeneration that underlines Parkinson's disease and than simply controlling the symptoms, which we are presently doing. By stimulating presynaptic receptors, newer drug may reduce endogenous dopamine production and release, thereby diminishing the oxidative stress, which is found to be the underlying factor for this. Another strategy under the study is the use of compounds that augment cellular energy metabolism, such as coenzyme 10, a cofactor required for mitochondrial electron transport chain. So with this, we can see that we have attempted here to summarize what is Parkinson's disease, how is its progression, what is the underlying cause of it, and can we correct any of these causes, and what are the most importantly, what are the precautions we have to take while administering therapy without ignoring the fact that this disease is actually a part of senile dementia, neurodegenerative disease commonly seen in elderly patients. So we have to take care of that as well. Okay, so I hope you found this lecture interesting. Thank you very much.